Welcome. Today we take on the blood vessels of the liver. 4 diseases: portal vein thrombosis, splenic vein thrombosis, Budd-Chiari syndrome, and sinusoidal obstruction syndrome. Most of us file these as 4 unrelated names. They are not. They are one organ and one question. Where does the blockage sit? Block the blood going in, and you get one picture. Block the blood coming out, and you get a completely different one. We will build the plumbing first, then walk 4 short cases through it. By the end, you should be able to hear a history and place the clot before the imaging comes back. 3 patients, 3 very different nights. The first is a woman recovering from pancreatitis who starts vomiting blood. The second is a young woman with weeks of belly pain and a liver you can feel below the ribs. The third is a stem cell transplant patient who has gained 4 kilograms in 3 days. All 3 have a clot somewhere in the hepatic circulation. Same organ, completely different stories. Before we teach a single fact, ask yourself what could possibly separate them. The answer is not the clot itself. It is the address. Here is the plan. First, we trace blood in through and out of the liver. 2 vessels in, sinusoids in the middle, hepatic veins out. Second, we build the single idea that separates these diseases: an inflow block versus an outflow block. Then we run 4 cases: portal vein thrombosis, and how to work it up and anticoagulate it; splenic vein thrombosis and its one unmistakable clue; Budd-Chiari syndrome and its gold standard test; and sinusoidal obstruction syndrome, a diagnosis you make at the bedside. Let us start with the plumbing. Everything that follows depends on this next block of slides, so slow down here. The anatomy is not decoration. The anatomy is the diagnostic algorithm. If you know the circuit, the 4 diseases sort themselves out almost automatically. Follow the blood. Step 1. 2 vessels enter the liver, the portal vein carrying nutrient-rich blood from the bowel, and the hepatic artery carrying oxygen-rich blood from the aorta. Roughly 3/4 of the flow arrives by the portal vein. Step 2. Both streams empty into the sinusoids, wide leaky channels that run past plates of hepatocytes. Step 3. The cleaned blood collects in the central vein at the middle of each lobule. Step 4. Central veins feed the right and left hepatic veins, and those empty into the inferior vena cava. In, through, and out. Now zoom in. The liver is built from lobules, small repeating units. At every corner of every lobule sits the portal triad. 3 structures traveling together. Follow the first branch, the portal vein, nutrient-rich but oxygen-poor blood arriving from the bowel. The second branch, the hepatic artery, oxygen-rich blood arriving from the aorta. And the third branch, the bile duct. Here is the detail worth keeping. Blood flows from the corner toward the center. Bile flows the other way, from the center out to the duct at the corner. 2 directions of traffic in one small space. Stay inside the lobule and watch the flow. Notice here at the edge, portal blood and arterial blood mix as they enter the sinusoids. That mixing is the point. Every hepatocyte gets both nutrients and oxygen. Next, the blood crosses the plates of hepatocytes. This is where the work happens. Then follow the pathway inward. All of it converges on the central vein, and from the central vein into a hepatic vein, and then into the inferior vena cava. One narrow channel carries the entire output of that lobule. Hold on to that. A narrow channel is an easy thing to block. This is the slide to remember. On the left, block the inflow, a clot in the portal vein. Pressure backs up behind the liver. You get portal hypertension, a big spleen, and varices. But look at the liver itself. It is not congested, so the liver tests are usually normal. And ascites is uncommon, but only if the patient is not cirrhotic. In cirrhosis, both of those flip. On the right, block the sinusoid or the outflow. Blood gets into the liver and cannot leave. The organ engorges. Now the liver is large, painful, and tender, with ascites, weight gain, and a climbing bilirubin. So ask one question first. Is the liver congested? Now place the 4 diseases on that map. The root question: where does the blood stop? The first branch is presinusoidal, before the liver. That is portal vein thrombosis and splenic vein thrombosis. The second branch is sinusoidal. The blockage is inside the lobule itself. That is sinusoidal obstruction syndrome. The third branch is postsinusoidal, the hepatic veins or the inferior vena cava. That is Budd-Chiari syndrome. And notice the outlier. Splenic vein thrombosis sits so far upstream that it barely touches the liver at all. Now the cases: 4 patients, 4 clots. We will do each of them the same way. A short history and exam, then a pause for you to commit to an answer, then the confirmatory test, and the next step. Case 1. Ruth is 44. She has had 3 days of steady abdominal pain and a swelling belly. Her temperature is 38.4 degrees Celsius. She is not jaundiced. Her liver edge is not enlarged, and it is not tender. Her spleen tip is palpable. She started an oral contraceptive 4 months ago. And here is the part that fools people. Her liver tests are completely normal. So think about where this clot has to be, and think about what that fever adds to the picture. This is acute portal vein thrombosis. Doppler ultrasound shows no flow in the main portal vein. Contrast-enhanced computed tomography confirms it and shows the clot has not extended into the mesenteric veins. Her liver tests are normal, and that fits perfectly. The liver is not congested because the blockage sits in front of it. The hepatic artery keeps perfusing the organ. The fever is the other half of the answer. Fever with a fresh portal vein clot means you go looking for pylophlebitis, septic thrombophlebitis of the portal vein. So what exactly is portal vein thrombosis? A clot in the portal vein, often with extension into the mesenteric vein or the splenic vein. And that extension is not a detail. It changes management. So always ask the radiologist how far the clot goes. Physiologically, this is an inflow block. Pressure rises behind the liver, and the liver itself keeps its arterial supply, which is why the organ can look and behave normally from the outside, while portal pressure climbs on the inside. Why does a portal vein clot? 2 buckets. The first is cirrhosis, sluggish portal flow through a scarred liver. That is the single most common setting. The second bucket is a hypercoagulable state, malignancy, intra-abdominal infection, oral contraceptives and pregnancy, inflammatory conditions like Behçet disease, inflammatory bowel disease, and collagen vascular disease, and then injury, recent surgery or abdominal trauma. If none of those is obvious, that is your cue to send a hypercoagulable workup. Portal vein thrombosis presents 2 ways: acutely, abdominal pain, distension, fever, or hepatic decompensation, and a large share are silent, discovered on an ultrasound or a scan ordered for something else entirely. Chronically, it is usually silent as well. When it does speak, it speaks with portal hypertension, hematemesis from bleeding varices, a big spleen, encephalopathy, and here is the discriminator. Ascites is uncommon in chronic portal vein thrombosis, unless the patient also has cirrhosis. 2 findings change the acute plan immediately. The first, if the clot extends into the mesenteric vein, the patient can present with intestinal infarction. That is bowel at risk, and that is a surgical conversation. The second, if there is fever, consider pylophlebitis, septic thrombophlebitis of the portal vein, usually seeded from an intra-abdominal infection, such as appendicitis or diverticulitis. Both of these hide inside what looks like a simple clotting diagnosis, so look for them on purpose. Look closer at the chronic picture. Most of these are found incidentally. When symptoms do appear, they are the symptoms of portal hypertension, hematemesis from variceal bleeding, an enlarged spleen, and encephalopathy. Now the point I want you to keep: ascites is uncommon here, and that is not a trivia point. It is mechanism. The sinusoids are not congested. The blockage sits upstream of the liver. Add cirrhosis to the picture, and ascites appears, because now the sinusoids are hypertensive too. Here is the sequence. First, the liver tests. They are usually normal. Do not let that reassure you. A normal panel does not exclude this diagnosis. Second, ultrasound with Doppler. That is the first test, and it is usually enough to raise the flag. Absent flow in the portal vein. Third, confirm and map the clot with contrast-enhanced computed tomography or magnetic resonance angiography. How far does it extend? Angiography if the picture is still unclear. And fourth, if there is no obvious cause, send a hypercoagulable workup. When the clot has been there a long time, the body adapts. Follow the first branch. A portal cavernoma, a network of collateral veins that grows around the blocked segment. The word to know is hepatopetal, meaning toward the liver. These collaterals carry blood back into the liver around the obstruction. It is the body rebuilding its own inflow. Now the second branch. Those collaterals sit right beside the bile duct. Rarely they compress it and obstruct it. That complication is called portal cholangiopathy. Anticoagulation splits on one question: does the patient have cirrhosis? In the non-cirrhotic patient with acute thrombosis, start low molecular weight heparin, then move to warfarin, or a direct oral anticoagulant for 6 months. Make it indefinite if the underlying cause is irreversible. In the cirrhotic patient, anticoagulation is recommended for acute complete main portal vein thrombosis, or for extension into the mesenteric veins, and you weigh the bleeding risk every time. In chronic non-cirrhotic thrombosis, Long-term anticoagulation is reserved for a permanent prothrombotic state, for recurrent thrombosis, or for extension into the mesenteric veins. In cirrhosis, consider transplant for symptoms or progression. One rule before you write for heparin: screen for varices. In every one of these patients, acute or chronic, if high-risk varices are present, treat them first. Start a non-selective beta blocker for bleeding prophylaxis, and then begin anticoagulation. Think about why. You're about to thin the blood of a patient who has high-pressure collateral veins sitting in the esophagus. Doing that blind is how a manageable clot becomes a catastrophic bleed. Screen first, protect, then anticoagulate. Case 2. Marco is 51. 6 weeks ago, he was hospitalized with severe pancreatitis. Tonight he has vomited blood twice. His spleen is enlarged. He has no stigmata of chronic liver disease. His liver tests and his platelet count are normal. Endoscopy shows large varices in the stomach and a completely clean esophagus. That last detail is the entire case. Gastric varices with no esophageal varices. Sawich vein is clotted. This is splenic vein thrombosis. The splenic vein runs along the back of the pancreas, so local inflammation, most often pancreatitis, can clot it. Now the spleen has to drain some other way. Blood detours through veins in the wall of the stomach, which enlarge into isolated gastric varices. Meanwhile, the portal vein is open. The liver is normal, and portal pressure is normal, which is exactly why the esophagus is clean. For bleeding gastric varices from splenic vein thrombosis, the treatment is splenectomy. Walk the mechanism one step at a time. Step 1. Pancreatic inflammation. The splenic vein lies right against the pancreas, so it takes the hit. Step 2. The vein clots, and splenic outflow has to find another route. Step 3. Blood detours through the short gastric veins into the fundus of the stomach. Step 4. Those veins enlarge into gastric varices and they bleed. Now notice what never happens. The esophageal veins are never recruited. Remove the spleen and you remove the inflow to that entire collateral bed. The bleeding stops. Case 3. Aisha is 33. 6 weeks of right upper quadrant pain and an abdomen that keeps getting bigger. Her liver is palpable 6 centimeters below the costal margin, and it is tender. She has shifting dullness and dilated veins across her flanks. Her transaminases are moderately elevated, and her alkaline phosphatase is up. Now look at the blood count. Her hematocrit is 54%. Her platelet count is 610,000. So where is this clot? And what drove it? This is Budd-Chiari syndrome, hepatic venous outflow obstruction. The liver cannot drain, so it engorges, which explains the large, tender liver. The pain and the ascites. Doppler ultrasound shows no flow in the hepatic veins. Now the driver. A hematocrit of 54% with a platelet count above 600,000 is a myeloproliferative disorder until proven otherwise. In her case, polycythemia vera. So send JAK2 mutation testing. About half of all Budd-Chiari cases trace back to that group of disorders. Let us define it precisely. Budd-Chiari syndrome is obstruction of hepatic venous outflow. The block can sit in the hepatic veins, in the inferior vena cava, or in both. The consequence is two things at once: sinusoidal congestion and portal hypertension. And there are two forms. Primary means the problem is inside the vessel, usually a thrombosis. Secondary means something outside the vessel is compressing it, a tumor or another mass pressing on the vein. Same physiology, very different treatment. Where does it come from? Here is the headline number. About 50% of cases come from myeloproliferative disorders associated with JAK2 mutations. Polycythemia vera is the classic example. Next, systemic hypercoagulable states, oral contraceptives, and pregnancy. Then tumor invasion, hepatocellular carcinoma, renal cell carcinoma, and adrenal tumors growing into the vein. Then trauma or compression from outside the vessel, and a real share stay idiopathic. One practical note: a normal blood count does not exclude a myeloproliferative disorder. Here is the diagnostic ladder. First, the liver tests. The transaminases and the alkaline phosphatase may be elevated, or they may not be. Second, Doppler ultrasound of the hepatic veins. This is the first test, and it runs about 85% for both sensitivity and specificity. Third, contrast-enhanced computed tomography, or magnetic resonance phenography. Look for the occluded vein, and look for an enlarged caudate lobe. Fourth, hepatic venography is the gold standard. A spiderweb pattern plus a measured venous pressure. Biopsy only if it is still unclear. 3 numbers worth memorizing. First, About 50% of Budd-Chiari cases come from myeloproliferative disorders carrying JK2 mutations. That is why the blood count matters as much as the imaging. Second, Doppler ultrasound of the hepatic veins performs at about 85% for both sensitivity and specificity. Good enough to start with, not good enough to finish with. Third, the caudate lobe. It enlarges because it drains directly into the inferior vena cava through its own separate veins. So it keeps draining while the rest of the liver cannot. Treatment climbs a ladder. Step 1. Treat the underlying condition. Manage the myeloproliferative disorder, or whatever else drove the clot. Step 2. Anticoagulate. Low molecular weight heparin and then warfarin. Plan on treating indefinitely. About half of these patients have an underlying myeloproliferative disorder, and that cause never goes away. Step 3. Open the vein. Consider thrombolysis if the presentation is acute, and angioplasty with a stent if there is a short stenosis. Step 4. Decompress. A transjugular intrahepatic portosystemic shunt, or a direct intrahepatic portosystemic shunt placed under ultrasound guidance. And liver transplant for acute liver failure, or when everything else fails. Case 4. Devin is 27. He is 14 days out from an allogeneic stem cell transplant for leukemia. His conditioning regimen included cyclophosphamide. In the last 3 days, he has gained 4 kilograms. His liver is enlarged and tender. His bilirubin is 4.6, and his platelet count keeps falling despite repeated transfusions. A Doppler study shows that flow in his portal vein has reversed. It is running away from the liver. So what is happening inside this organ? This is sinusoidal obstruction syndrome. A toxic insult has injured and occluded the small hepatic venules and the sinusoids themselves. The liver will not accept blood, so flow in the portal vein reverses, and everything backs up. That gives you the picture at the bedside. Rapid weight gain, a tender enlarged liver, ascites, and a rising bilirubin. And notice the platelet count falling despite transfusion. That is one of the classic clues, and it usually shows up early. Let us be precise about the lesion. Sinusoidal obstruction syndrome is occlusion of the hepatic venules and the sinusoids. You will still hear it called veno-occlusive disease. That is the old name. The mechanism is a toxic insult to the lining of those tiny vessels, not a clot in a large vein. So put it on your Mapone level upstream of Budd-Chiari. The physiology is the same. Blood cannot get out of the liver. The address is different, inside the lobule rather than in the hepatic vein. So who gets it? The big one is hematopoietic stem cell transplantation. Roughly 15% of patients, which is why every transplant service watches for this. The insult is usually the conditioning chemotherapy. Cyclophosphamide and cytarabine are the 2 named agents. Radiation to the liver adds to the injury. And then there is bush tea, an herbal tea and a classic cause worldwide. Easy to miss if you never ask. So take the exposure history. It is often the whole diagnosis. Here is the part that gets missed. This is a clinical diagnosis, not a radiologic one. Look for early weight gain, often the first sign, a platelet count that will not hold despite transfusion, a rising bilirubin, and a history of recent toxin exposure. Ultrasound helps. Reversal of portal flow supports it. And if you still need proof, a liver biopsy, or a hepatic venous pressure gradient above 10 millimeters of mercury. But the bedside makes this diagnosis, and it makes it earlier than any scan will. Treatment. Most of it is supportive. Manage the fluid with diuretics and careful volume control. For severe disease, early defibrotide improves survival. And the word early matters. Waiting costs you the benefit, but be honest about the trade-offs. Defibrotide has side effects, and it is expensive. For prevention, defibrotide again in high-risk patients. Deoxycholic acid for high-risk stem cell transplant populations. Low-dose heparin prophylaxis has been tried, and it remains unsettled. Here they are together. Portal vein thrombosis, an inflow block. The liver is not congested, so expect portal hypertension with normal liver tests, unless the patient is cirrhotic. Splenic vein thrombosis. Even further upstream, the liver is untouched, and the signature is isolated gastric varices. Budd-Chiari syndrome, an outflow block. A big tender liver. Look for the enlarged caudate lobe and the spider web. Sinusoidal obstruction syndrome. Blocked inside the lobule. Again, a big tender liver, usually after a stem cell transplant. One question sorts the whole table. Is the liver congested? 5 points to carry with you. First, normal liver tests do not rule out portal vein thrombosis. They are usually normal. Second, fever with a portal vein clot means you look for pylophlebitis. Third, screen for varices before you anticoagulate. and give a non-selective beta blocker first if high-risk varices are there. Fourth, gastric varices with a clean esophagus. Look at the splenic vein and think pancreatitis. Fifth, a big tender liver with new ascites is an outflow problem until proven otherwise. These are the published sources behind what we covered. The recent reviews on portal vein thrombosis, Budd-Chiari syndrome, and sinusoidal obstruction syndrome, along with the position paper on vascular disorders of the liver. Always check anticoagulation and shunt decisions against current guidance from the American Association for the Study of Liver Diseases and the European Association for the Study of the Liver, and against your own hepatology service. Thanks for working through the hepatic vasculature with me.